Hello, everybody, and welcome to the webinar. Thank you for joining us on this joint perinatal outreach education program and community perinatal network webinar on skin-to-skin safety, reducing the risk of sudden unexpected postnatal collapse. The handouts will be available after the webinar, and a PDF will be emailed to all who have registered. And a question-answer time will be available at the end as well. You'll see a box in your webinar to be able to type in those questions. Feel free to write your questions to us as they come to you. We will get to them as best we can at the end of the presentation. If you have trouble, feel free to go ahead and put that into the question area as well, and we'll try to answer those as we go along. I'd like to introduce our speaker today, Connie von Kohler. She is the Program Director for the Perinatal Outreach Education Program, the Regional Perinatal Programs of California, and the Maternal Transport Program at Miller Children's and Women's Hospital at Long Beach. She's worked with several hospitals and the region in implementing skin-to-skin practices in a safe and effective manner. I turn the program over to Connie.
Thank you, Lucy. Today we're going to talk and describe what is an unexpected postnatal collapse, review safe skin-to-skin practices to prevent it, and identified methods to monitor babies during skin-to-skin contact. I first want to give a few acknowledgments. One to Los Angeles County Regional Hospital Breastfeeding Consortiums. The county put this program together a few years ago, and the main people involved, besides all the birthing hospitals, the people coordinating it, are Breastfeed LA, the LA County Health Department, WIC, and the Regional Perinatal Programs of California. And many of you know LA County is quite large. So the county, we divided it into northeast, south, and west. And there's a small planning group for each area and then one large planning group for the whole county. And I participate on both of those and work with the South group, which is about, I want to say, 18 or 19 hospitals. And for our meeting that was in August, we looked at this topic. And I said I'd be happy to do it if I couldn't find an educator or a CNS in the South group who would take it on. And nobody did, so of course I did. And so I want to give some credit to Providence Holy Cross because they had done an in-service and some education for their staff, and they wanted to share the information. So my presentation actually ended up being built upon what they had started. Then I'd also like to give a shout out to Sharp Mary Birch in San Diego. When I took this on and started looking at this was back in, I want to say, June for the August meeting. And in June at our National A1 conference, which was held here in Long Beach, there were two presenters from Sharp Mary Birch who did a presentation on safe sleep, balancing skin-to-skin contact with the risk of sudden unexpected postnatal collapse. And so I did attend their presentation, and so I want to credit them for having, I'll just say, the guts to get up and share their experience and where they've gone. And then lastly, I want to thank my colleagues at the Community Perinatal Network and Lucy Van Otterloo, who I work with for Orange County and doing some of the same regional hospital breastfeeding consortium activities in Orange County. The goal to move all those hospitals to compliance with SB 402, which is incorporating the baby-friendly 10 steps. And when I told Lucy I had done this for my group in LA, I offered to do it for Orange County, and she said, hey, what about a webinar? Great idea, I said. So here we are today, and thanks everyone for joining. So when you look at what is sudden unexpected postpartum collapse, what is the definition? Well, it kind of really depends, because when I started doing a lit search to find out more about this topic, I found that there were a lot of definitions in the literature and people looking at these episodes in a lot of different ways. So we haven't really internationally come up with one designated definition, but here are the titles that have been given out at this point. And probably, I know one person said to me, "Oh, Connie, it's nothing more than just another version of SIDS." And that may be true. It sort of is a little bit like SIDS, or sudden unexpected infant death. But we do know that with sudden unexpected infant death now, according to the CDC, there are 3 different types. So sudden unexpected death syndrome, or SIDS, unknown causes, and accidental suffocation and strangulation in bed. But probably the most pulled together definition by these Swedish authors here is the sudden unexpected postnatal collapse is the sudden collapse of an apparently healthy infant within the first days of postnatal life. And they're looking really at babies that are 35 weeks gestation or greater, a 10-minute APGAR score of greater than 7, and considered really a healthy baby who collapsed suddenly and unexpectedly within the first postnatal week. So the etiology that we have found out there are a lot of similarities with SIDS. SIDS, however, has the triple risk hypothesis, having that underlying genetic or developmental predisposition. Is there a cause of death? It could be unknown, and the deaths in the first week are often not included in SIDS databases. So these cases of sudden unexpected postpartum collapse, that data may not be found in SIDS, and we don't really have a good understanding of how many cases there are out there, and a definition of what all has been happening. What I found in the literature when I went looking is most of the case presentations in the literature are all coming from Europe, and there was only one case discussed since January of this year. That was a case in New York City. So people are starting to look at it and give some more thought to what is happening. What we do know is that sudden unexpected postpartum collapse is associated with prone position, skin to skin, and co-bedding in 74% of the cases that have been reported. Of the published cases, because the definitions vary so much, it's really hard to know what the percentage and how many cases there really are out there. I don't know that if in the United States it's even being recorded this way, and if we're really collecting that data. But we really need to thank our European colleagues, Sweden, France, England, Germany, Austria, and Italy, for the amount of information that they have shared in the literature. And after the information went out for this webinar today, I've had 4 different people call me within the last week and a half to share their stories of things that happened in their hospital. And it was very disturbing to me to know that there's so much anxiety and so much heartbreak that's happened, and we haven't been sharing this information. So when you think of when these accidents happen or a situation happens and a baby that we thought was healthy and normal dies or has great sequela because of suffocation, there's more than just that family and that baby. There's that nurse, and I'm calling that nurse the second victim of this whole situation. And I think it's important for us to remember that we did what we knew, what we thought was best, and now we're learning that maybe there's something else we should be doing. So we've got to really support our nurses who are taking care or have taken care of these babies in these situations and are feeling like maybe they need to leave nursing, or what did they do wrong, because they did what they were taught and what they thought was the right thing to do. And now it's coming out that we really need to really look at how we're assessing and positioning these babies. So what we have found out from the literature is half of these infants have died, and there was no etiology found when autopsies were done. Most recently in the Swedish literature, that half of these survivors did have some neurological sequelae, and they did had developed hypoxic ischemic encephalopathy, and they have started to treat some of them with hypothermia treatment and had had some success with that. So that's kind of an interesting way to deal with the situation, and certainly kind of the same, looking at it the same way as if it had been an interpartum situation. What we do know about the cases that have been reported so far is a third of them happen in that first 2 hours of life. So during that initial skin-to-skin time. The second third happens within 2 to 24 hours. And the final third happens within the first week of life, so from day 1 to day 7. And most of those actually within the first 3 days. So what I found from the cases that were reviewed, they looked at cases that were 34 to 35 weeks or greater. These were babies that were of normal weight. They had no congenital anomaly or other identified issues. They were considered good condition. APGARs were 7 or 8 at 5 minutes, and there was no evidence of any resuscitation beyond the initial suctioning of the airway. Common denominators from those cases that were reviewed is that with basically most of them had happened within the first 2 hours of birth. The babies were prone or side position on the mother. The babies' heads were covered and not visible. Mom was supine. In many of the cases, the moms were primiparous, so their first baby. The mom and infant was not being observed during the initiation of skin-to-skin and the first breastfeeding. Parents were left alone with the baby during the first hours after birth. And in some cases, the mother was distracted with electronic devices, texting her friends. So skin-to-skin contact, we know the great benefits of skin-to-skin contact, and in no way does the literature or am I trying to imply that we should not be doing skin-to-skin or that we need to change skin-to-skin, but rather looking at how we're initiating it and how we're observing and assessing mom and baby. Recommended for we know that skin-to-skin contact is recommended for all healthy babies. Due to the physiologic and the bonding benefits, and we all know that and we support that, it helps to regulate babies' temperatures and prevent hypothermia. Neonatal blood glucose regulation, and it helps with the prevention of hypoglycemia. Initiation and maintenance of exclusive breastfeeding, and it enhances milk production. And skin-to-skin contact enhances that mother-infant relationship or the mother-father relationship. I've heard wonderful stories of dads getting to do skin-to-skin in the OR when mom wasn't in a situation to be able to do that. So we want to continue this practice of skin-to-skin. And it can be done immediately after birth and is supported by the AAP until the first feeding at the breast has been achieved. And we want to continue to support this practice. So what do we know? We know that there's risk factors, though. The babies are vulnerable during transition. And when they're in a prone position, when their head is covered, and that first time that they're attempting to breastfeed. We know from the literature that there's maternal risk factors. When the mom is supine, when she's a first-time mother, if she's obese, if the mom is left alone with no RN supervision, moms who are tired and medicated, whether it's for analgesia, whether they're sedated, or magnesium sulfate. And I would just say that probably 99% of our moms fall into that right there. Moms who are distracted with mobile devices, texting and social media, FaceTiming, or whatever they might be doing. That's probably a time we need to ask them to put that cell phone away. And then moms who are doing bed sharing with their babies. So what should we do? Well, we know if we look at staffing guidelines from A1 and from the AAP ACOG guidelines for Care 7th edition, they give us some direction for how we should be providing nurses to care for moms and babies. So A1 supports having 2 nurses in attendance until those critical elements for both patients are met. So 1 nurse for the mom, 1 nurse for the baby until they're stable. And in which case, then 1 nurse can care for both the mother and baby. So what are the recommendations that I found in the literature? We're talking about, number 1, safe early skin-to-skin in the delivery room, and safe breastfeeding establishment in the first days of life, and secure positioning of the infant during sleep. So safe early skin-to-skin in the delivery room. We really need to provide continuous surveillance. So sometimes it's easy when we think the mom and the baby are doing fine for nurses to get distracted with all those other jobs and tasks that need to be taken care of and that we need to do. But we really do need to have a caregiver who is focused on the baby during those first postnatal hours and who making sure that there is always a nurse in the room and that nurse isn't leaving and going to other rooms and checking on other things or charting outside, that there always stays a nurse in that room. And that she positions herself so that she can easily see the mom and the baby. So maybe you do have charting and things to do, but can you visually see them very easily? And so then also reduce the risk of distractions for both the nurse and the mother. An ongoing assessment during that recovery period and making sure that that baby is breathing and is moving. Can you see them breathing? And what is the color and the tone? So safe breastfeeding establishment in the first days of life. So how do we work with those moms so that we observe the correct and safe positioning? Nowadays, a lot of nurses have cell phones on them at work. They have a closed system within the hospital where the nurse has a phone where the patient can call her. So making sure that mom has the phone number of the nurse so she can call her, so she can tell her when she's going to be breastfeeding so the nurse knows to go in at that time and check on the mom. When babies are doing skin-to-skin with mom, is it tummy to tummy and chest to chest? Is the nose free and uncovered by breast tissue? Is it uncovered by a blanket so you can easily see that baby's head and face? And is their neck and their head aligned? So sometimes you see babies get kind of crunched up or their heads are turned in a funny angle. So really looking at that head and neck alignment. So secure the positioning of the infant during sleep. So all newborn infants should be placed in a supine position within the first few hours after birth, and emphasized that's emphasized in the reports of sudden unexpected postpartum collapse and in the guidelines to reduce the risk of SIDS that we need to put those babies on their back in the bassinet. And the nurses need to be modeling these safe sleep behaviors and explaining that to the patient every single time they do it. And so when the patient is breastfeeding or doing skin-to-skin, remind the mom that if you start to feel sleepy, please call me so I can help you put that baby back in the bassinet on the baby's back. Something I've noticed that I wanted to bring your attention to and direct you to is in the Maternal Child Nursing Journal, there's an article written by Kathleen Rice Simpson and on perinatal patient safety. And I like to read this article every edition when it comes out. And I'm one of those people, I guess, when Kathleen Simpson speaks, I listen. And in the July-August edition, the article on perinatal patient safety focused on newborn safety in the hospital. And she talked about I think it's 5 common sense approaches to newborn safety. So I'd like to direct you to that article, and perhaps if you have trouble getting a hold of it, please contact me, and I'm sure Lucy Van Otterloo as well. We'd be happy to send it to you if you have a difficult time getting it. But it really looks at what nurses and hospitals need to be doing to provide safety for their newborns. And then in the edition that just came in my mailbox this week, the article is on nurse staffing and care during the immediate postpartum recovery period. And she talks a lot about those assessments that we should be doing for the baby and looking at their color and their position and their activity and their tone. And how often should we be documenting this? She's saying every 30 minutes until the baby is stable for 2 hours. I would hate for, a lot can happen in 30 minutes, and I am by no means suggesting we need to be documenting every 5 minutes, but certainly we need to have continuous observation and continuously looking to be sure that that baby is doing well. So what tools are out there and what can help us to make sure that we're providing a safe environment? This particular slide looks at when babies are supine and when babies are prone, because there are still people out there who think that babies are okay to be laying on their stomach, and we know from Back to Sleep that there's been great improvements on babies' outcomes when we're keeping them back on their back. So in one hospital, and I want to say it was CHLA, they have printed these small enough that nurses have them in their pocket or have them on their ID badge, so they're able to show parents and explain to, the grandma, friends, all those people who still want to put their baby on their stomach, why that's dangerous and how babies benefit from being supine. If you go to the website of www.kangaroo care, I want to say it's USA, Susan Ludington, and probably most of us are familiar with Dr. Ludington and the work that she's done on skin-to-skin and kangaroo care. And they have developed this competency checklist, and it's certainly something to give some thought to looking at this and implementing this, or at least educating your staff of what they should be doing and how babies should be positioned, and the documentation, the ideas for documentation that she has here. So it's a really good tool and something to give you some direction and easy to find. Also, there's the thought of putting posters or checklists in rooms so that they're easy to show to patients and to educate them. So this particular one has been put at Providence Holy Cross, and my understanding is they have it laminated with like Velcro on the back and a little Velcro piece on the wall, so the nurse can take it off and talk to moms and explain to moms how it's used and how babies should be positioned for safe skin-to-skin contact. It makes a wonderful reminder for staff if you have that up so they can look and see. So really, is the baby's face, can it be seen, both the mouth and is it uncovered? Is the baby's head slightly tilted up and turned to one side? Is the baby's neck straight and not bent? Are their shoulders flat against the mom, chest to chest with mom? Can you see the chest movements when the baby's breathing? Are the baby's knees bent and up? So that's kind of what's holding them up. And tucked, the blanket tucked under the mom so the baby's nice and secure. The baby pink and warm. Is the mom positioned in a reclining position, so not flat and not straight, sitting straight up? And reminding nurses to check on moms. And this one says both mom and baby are checked upon while sleeping. Hopefully the baby is not on mom while mom is sleeping, but is put back into the bassinet. We don't want babies and moms asleep in this position. Also, I found in this article by this Italian author a checklist for newborn infants in the first 2 hours of life, and it was particularly during skin-to-skin contact. So they were suggesting having this kind of a checklist. It might be something that you could easily put into your electronic charting, your documentation flow sheet type of thing. But certainly looking at these parameters and things to be looking at. So are the infants positioned so they're visible? Again, unobstructed nose and mouth. Looking at the color, looking at their normal breathing. They have a normal respiratory rate. From this article, they were kind of suggesting if you were going to use like a pulse oximeter, and then the baby's temperature, and making sure, again, number 7, the mother is never left alone with her infant during that time period and was breastfeeding attempted. But those are just some ideas of a checklist or observation that you may want to incorporate into your documentation. So what I found was advice to healthcare professionals in the first 2 hours of life. Don't leave that mother unattended, especially a prima gravida. Ensure and verify the appropriate infant positioning during skin-to-skin contact with the nose and mouth uncovered and well visible. If the baby is in a prone position, it should be accepted if the infant is chest to chest, and making sure that the baby's not turned maybe sideways, and that the head is turned to one side, and that the neck is straight, and again, that the mouth and nose are uncovered. Prone position of the newborn should be accepted only during supervised skin-to-skin contact, and avoid skin-to-skin contact when moms have been given analgesia or they appear tired unless the staff can provide that continuous monitoring. And first breastfeeding attempts should be supervised and supported, and help the mom with what she's doing, not just telling her what to do and then turning your back and going around cleaning up rooms or charting or whatever nurses might get themselves involved in, or being pulled to take care of another patient. So we certainly need to be cognizant of how long, when we're making assignments, nurses need to be able to do the job correctly. So advice to the healthcare professionals after the first 2 hours of life. So bed sharing should be discouraged. If the mom is sleepy or sleeping and the mother-infant dyad is unattended. And the thing I also think to think about, sometimes we think, well, they have a family person in there or a significant other, there's somebody with them so they're not unattended or they're not alone. But we need to take into consideration that other person. So was this a significant other or a support person who was with them during labor? And is that person just as tired because they were up for 24 hours? And are they going to fall asleep in the cot or the little bed next to mom, and so we're all asleep? Or is this patient person awake and alert and full of energy and can kind of keep an eye on things. So you have to take that into consideration as well. Babies that are found bed sharing with a sleepy parent should be placed in the cot, or as we would say in the United States, a bassinet. And we need to tell moms, when you're starting to feel sleepy or the significant other person in the room, if you're feeling sleepy, call us. We'd like to help put that baby back in a safe position. Now, the recommendation from this Italian author also said that side and prone position of the newborn should be discouraged, and AAP basically says that you should not do it, period. So that's why I put the red line through it. So because our guidelines are saying they shouldn't not be discouraged, it should just not be allowed, and especially when they're in the hospital, we shouldn't allow that to be happening. And we should discourage that with the families when they're going to take their baby home. Prone position of the newborn should be accepted only during supervised skin-to-skin, and recurrent checks on the mom and the infant should be required, and if needed, position the infant differently. So it's not just going around and checking in rooms and saying, hi, are things okay, but actually making the effort to walk over and assess that baby and making sure that baby's in the correct position. Well, what advice should we be giving moms? So we should be teaching them about safe sleep and the need to be on their backs for sleeping. We need to tell moms they should not be putting their babies prone or on their side, and that prone positioning is accepted only during supervised skin-to-skin and if the mom is not sleepy or sleeping. That during skin-to-skin that the mouth and the nose should be visible and uncovered at all times, and the head should be turned to one side, the neck should be straight, and the infant should be chest to chest, not over a breast or between breast or over an abdomen. And we really need to watch that very carefully with our obese patients. And we know that's an increasing population that we're all dealing with, so we really need to be careful with those. We need to talk to our patients about giving their attention to their baby and to breastfeeding and understanding and getting to know their baby, and avoid the distractions of electronic devices. I don't know how you live now without your cell phone or our iPads or little mini devices, and our ability to FaceTime and Skype and all those things immediately, and it is an exciting time. If patients want to do that, we need to make sure that we're watching that baby, or that they've got somebody else watching to make sure. Maybe mom should watch the baby and somebody else can hold the handheld device. If mother feels tired or sleepy, that the infant should be placed in the crib or the bassinet. And ask for supervision for the first and subsequent breastfeeding attempts. So we need to make sure we tell moms, that we, the nurse, we want to be with you, we want to help you, please call me so I can be here. Make them feel free and comfortable to call, rather than feel like they're disturbing the nurse if they do that, but helping them to know that that is our job and that's what we're here to help them with. Other tools that I found in the literature, and again from Susan Ludington, was the RAP assessment tool that looks at respiratory effort, activity, perfusion, and position. This is what that checklist looks like, and I've heard of hospitals using this and implementing this and putting that into like their doc flow sheet or however they're doing their assessment. It certainly gives clear direction of what you want to be looking at and assessing during the skin-to-skin and breastfeeding. So now I have a series of pictures that I'll flip through, and you can look at them and give some thought to them. Certainly, if you do some education for your staff, finding some pictures that people can look at and then, okay, how am I assessing this baby? And so if I look at this, I think, oh, what do I see that's correct? Well, the baby's head is turned to one side. The face is uncovered, so we can easily see the face. It looks to me like this baby probably was just born, because it's still pretty dusky and has some blue fingers. So it's certainly something we want. Not knowing the time frame of when this baby was born is certainly something you would want to keep a watch on. The mom looks like she's very supine, so you would want to really keep a watch on her. Now this picture, I look at this picture and I think, oh, what a lucky baby to have such a dad who wants to lay there and do skin to skin with him. And you can see just from the father's hand on the baby's head that he's probably awake and alert. And the baby's covered, but his head is uncovered, so you can easily see the baby's head. The dad looks like he's probably not completely supine, but reclined, and everybody just looks great here. Now, this isn't the greatest resolution on this picture. It's pretty blurry a little bit, but I think it kind of helps to make a point. So when I look at this, what are the positive things that you all see? For me, well, the mom isn't completely supine. She's reclined. She does have her hand on the baby. The baby's head is uncovered, but from the view I have of it, it looks like the baby's head is tilted a little bit. Maybe this baby needs to be straightened up a little bit more. It's kind of hard to tell. The head is tilted maybe a little bit too much. And certainly the mom looks sleepy. So for me, at this point, I think this baby needs to be removed and put into the bassinet. Or maybe it needs to go into the isolette. It looks kind of little, so maybe that's where, if it's a NICU baby. But certainly when you have a mom who's that sleepy, the baby doesn't need to be left in her arms. So what do you all think of this one? When I look at this, I see, oh, a nice pink baby. Certainly the head's uncovered, but then so's the whole rest of the baby. So certainly the blanket needs to be pulled up over that baby's shoulders so we don't let that baby get cold. And I can't quite tell if this mom is asleep, and perhaps she is, and that's why the blanket is moved down, because maybe her arm has slipped down. So certainly if she is sleeping, it's a baby or a baby that would need to be removed. But it looks like maybe this baby has just breastfed, and it does have its head turned to the side, which is a good thing, and the color is really good. So this little guy looks like, or she, was just born as well, and initial skin to skin. And from this picture, the baby's nice and pink. It's a little hard to tell the position of the mom, but the head is not covered, and that's what we want. We can see the baby's head, and if you're the nurse, you can easily see that this baby, the color of this baby, and you would be able to see how the baby is breathing. Depending upon the situation here, we might need to straighten this baby up a little bit. It might be a little bit sideways. But certainly the color is good. Now this one, this kind of brings to light the idea that perhaps this is maybe a picture from a NICU, and it gives us some thought to think about how our baby's doing skin to skin in the NICU, and do we have recliners for these moms to sit in, or are they expected to be sitting like in a rocking chair or in a regular chair? And that's going to be hard for the mom and for the baby, and some type of a reclining type of chair might be a better option for her. Certainly, she looks like she's, it's not the best picture in the world, but it looks like she's awake and alert, and the baby's head is uncovered. We can't quite tell if the baby's legs are and knees are bent, so the mom is able to stabilize that baby that way. And it does look like the baby's kind of slipping down, so probably mom needs to be reclined a little bit. But otherwise, the baby's head looks like it's straight and maybe a little bit tilted a little bit more. This baby, well, certainly we probably need to pull this blanket down a little bit more because they've got the head so covered with the little cap. It's a little hard to see, but from this angle we can see that the baby still does have a pink face. But look how smashed his nose is. So I'm personally a little concerned here. We might need to help reposition this baby a little bit so it has a little bit easier time to breathe. And definitely keep a close eye on this one. Again, not the best picture, but I certainly think this one makes the point when we look at, yes, the mom is holding the baby, but we're missing a blanket here, and we need to keep that blanket around. This baby's head is face into mom, and the head needs to be turned to the side. And it's also a little scrunched up, so hoping to straighten out that neck and turn the head to the side would be a better option for doing skin-to-skin with this baby. And hard to tell exactly the mom's position, but hopefully she's reclining and not sitting straight up. I think this is the last picture I have to share with you, but you guys get the idea and what you could do with your staff. When I look at this, I see what a lucky baby to have such a happy dad who's so proud and is so willing to lay right there and hold his baby. Now, we might need to recline this dad a little bit, pull this baby up because you can put that blanket around him. Dad does have his hand on his baby, but the baby's head is down about Dad's tummy on his belly instead of pulling him up maybe on the chest a little bit more. And his head is a little bit scrunched, so his head needs to be a little bit straighter, but it is turned to the side and his color is good. And what a happy dad. What a great picture. So some strategies to minimize sudden unexpected postpartum collapse risk. So number one is safe positioning education. We need to educate our healthcare professionals and go back and think about when we're initiating skin-to-skin, and I'm not talking about making that change in your hospital, but if you've done it or you haven't, making sure that the nurses are educated as to what is a good safe position and what they should be doing to position those babies and monitor those babies. We need to educate new moms, both prenatally and in the hospital. So prenatally when she comes in on what to expect, and that's a good time to say, you need to leave your cell phone in your bag and let somebody else be the communicator to the outside world. And then when she comes in, explain to moms how this is going to go, why we need to keep their heads so we can see them, why a mom needs to kind of keep an eye on her baby, re-educating her the importance of letting somebody know if she's sleepy, and educating whoever she has with her, or family members or support people, so they know what to look for and when to call for help. Posters or checklists that you can keep in the room on the wall. One, it helps to remind patients. They get told a lot of information when they come in and can't possibly be expected to remember that. So having a checklist on the wall, similar to the one that I showed you from Holy Cross, is a great idea. Or posters that show the correct positioning. We as healthcare professionals need to model the items on that checklist. And whenever we're doing something, explain what we're doing and why we're doing it, so the moms hear the same message over and over from all the different care providers they have during their time in the hospital. The nursing staff really needs to know the risks and vigilantly screen who is a candidate for skin-to-skin, and if there's additional education or observation that needs to go on. One thing that I was very impressed with from Sharp Mary Birch when they did their presentation is they did create an early skin-to-skin algorithm and determine who was a candidate for skin-to-skin and who wasn't, and who could if they had additional observation and support to watch them. So maybe really trying to hone in on that, and so your staff is aware of who might be a good candidate and who do they need to change things for. Developing a routine assessment parameters. So being clear as to what the expectation is to assess and how frequent, and making sure that we've tried to create a documentation system that will allow the nurse to document that in appropriate time frames, and that we're giving nurses the time to do the documentation that we're asking and expecting them to do. And then lastly, the continuous monitoring of the dyad during skin-to-skin contact, the initiation of that during breastfeeding, both in labor and delivery and in mother-baby units. So, and here are my references, and again, we'd be happy to, we will make these slides available for you, so you'll have these references, and I'm open for questions. So, Lucy, are there any questions?
Okay. Thank you very much, Dr. for that. We don't have any questions at the moment, so attendees, please feel free to write in your questions. You'll find that under the control panel and under questions, and you can write it in there. We'll wait a couple of minutes to see if we have any questions coming through. And again, thank you, Connie, for your insights on this incredible topic in that. We do have a question.
Okay.
In the NICU, we do things such as prone positioning that need to later be undone with families. Prone skin-to-skin with premature baby on monitors, and the mother-father dosing is probably safe. The question is concerns, your take, Connie, on changing the practice on the NICU babies, prone chest positioning at home not being a good idea for dosing parents, and the education that goes behind that.
I would discourage families from doing that at home if they're dosing, because that's when they fall asleep and the baby slips down and gets, can easily get kind of wedged between a parent and a pillow, or end up sliding right off the bed, or the sofa, or wherever they are, or gets lodged somewhere. So I think we need to continue to educate patients that, when you go, while you're in the hospital, and then when you go home, if you find yourself getting sleepy and dozing off, put that baby back to sleep in a safe place.
Thank you, Connie. We have another question to please explain the color evaluation in dark-skinned babies.
Ah, well, there's a good one. And I don't know that I can. So I know that in some of what I read, they talked about using pulse oximeters, and perhaps that's a really good situation when you would want to use a pulse oximeter.
Great, that's a good comment there, especially in the difficulty of that coloration in the skin, and just increasing those assessments, or just watching closely for other signs as well. Another question, I know that Connie, you mentioned this, I think, in your first slide, but can you discuss the incidence rate of SUPC in the hospital setting?
I can only say that I think it really happens a lot more than we know. And in the literature, there was only been one article, and actually it was in the Journal of Human Lactation that came out in, well, this year, and I don't remember what month. Anyway, and it was from New York, and they talked about 2 reported cases of healthy neonates that suffered respiratory arrest in the mom's arms while attempting to breastfeed. And the way that investigation that I have looked into is some of those cases in the hospital maybe, well, we don't necessarily collect it as SIDS, and we don't have a code for this for like ICD-10 coding. So we don't have any data, or ICD-9, which would have been the one since before October. So we don't have data to show or tell us how often or how many cases we have had happened in hospitals in the United States or in California or in Los Angeles County. From talking to people just in the last few months, it seems like everybody's had one, and it goes to risk management and nobody talks about it, and sometimes they don't even talk about it within the hospital so that anybody else knows. And I was particularly distressed for 2 reasons. One, to hear that it was happening places and nobody was talking about it, not even within their own hospital. And 2, like I mentioned in the one slide, that it's happening and that nurses are so distressed that they're looking at leaving the profession or leaving OB because they're thinking they did something wrong. When really, as a profession, as maternal child, we haven't really focused on this. And now I see that we are starting to give some, realize that this happens and look at the risk factors and make some practice changes so that it doesn't happen. So to my knowledge, I have not seen any data that gives us any really clear direction as for definition to how many cases have happened, but they are happening.
Thank you. And again, I know you mentioned earlier about the A1 staffing guidelines. Can you just kind of touch on that again about how long should the nurse be in the continuous presence after delivery?
Well, as we know, staffing guidelines tend to be just that, guidelines, and they aren't really clear or very specific. What it says is the critical elements during postpartum recovery before the mother's nurse accepts another assignment. They're talking about how there has to be one nurse for the mother, one nurse for the baby until those critical elements have happened. And so, but they don't really necessarily define the critical elements. So I'm thinking that they're stable and the moms aren't bleeding. I will tell you, one of the cases I heard about from a nurse was that the mother started hemorrhaging, and everybody got caught up in taking care of the mom who was hemorrhaging, and nobody was focused on the baby. And when somebody did look over at the baby was already in secondary apnea, and the baby died. And it was skin to skin on the mom. So that's remembering that there's got to be somebody who's responsible for watching that baby. And when things start to happen, well, things aren't safe, then we need to move that baby and put that baby, on the isolette. That's what we used to do, or putting the baby in a bassinet or the crib that may be next to the mom. But A1 doesn't come right out and say how often one should assess. They leave that kind of open for you and for the different situations. So, but they do talk about making sure there's 2 nurses, and until they're both stable. And in Kathleen Rice Simpson's most recent most recent one that came out last week, she says the critical elements are usually accomplished within 30 to 45 minutes. So you really are looking at having 2 nurses in there watching mom and baby for basically 30, 45 minutes, perhaps an hour. The temperature, heart and respiratory, skin color, peripheral circulation, type of respiration, level of consciousness, tone, activity should be monitored at least every 30 minutes until the baby is stable for 2 hours. And she cites AAP and ACOG for that. So from reading this, I would take it up. You basically really need to have 2 nurses for at least the first hour, and then you still need to be monitoring and writing those assessments on those babies every 30 minutes for 2 hours. That's the guidelines that she has pulled together.
Great, thank you. We don't have any further questions. Thank you so much, Connie, for the great information on not only the importance of skin-to-skin, but how to do it right and how to do it well to address the concerns regarding safety. If you have any further questions for the attendees or you need assistance, please feel free to email myself, Lucy Van Otterloo, at the Community Perinatal Network, or Connie Von Kohler at the Perinatal Outreach Education Program. You'll receive the presentation slides handout in a couple of days. Feel free to respond to that email as well. Everybody, thank you for attending. And with that, I will end the webinar. Have a great rest of your day.
Thank you, Lucy.